thank Greg Nowakowski for replacing on a very short notice Jonathan Friedberg and accepting to fight against Sonali. And he asked to show us why polar RCP, CHP is not a new standard of care.
Thank you, Emanuele. And when I got this phone call, can you replace Jonathan Friedberg? I thought, sure, I'm talking a lot about induction therapy. I can probably do that. But then a lot of friends start messaging me like, do you know what you're doing? It's only you're debating. It's like, how bad it can be. Then, this picture pop up on the Google. I mean, it's formidable opponent. I mean, just look at this, right? So all the friends, all the human friends are saying she's difficult to debate, and I agree with it. So I decided to ask ChatGPT, how is Sonny Smith performing? And first, what you notice, she does it all the time. So she's a pro, okay? But then you can also notice that she's articulating clear, evidence-based, and respectful and collaborative, which we all know. So let's make it evidence-based. So our job has been a standard therapy based on progression-free survival benefit and overall survival benefit shown in multiple studies. You will also notice here that the separation of EFS or PFS curves occurs relatively early, reducing early risk of relapse. In the past, we have not accepted progression survival benefit alone as a practice-changing standard. This is the example of the SWOG study, which I think Sonny is co-chairing, as it happens, which shows that, for example, transplant consolidation, despite the benefit in the progression-free survival, was not accepted because of lack of overall survival benefit. And if you look at the POLARX trial, the benefit in progression-free survival is overall quite small. And this separation of the curves occurs relatively late. In fact, if you look at 6.5 difference at 24 months, the number needed to treat is about 15 patients who need to receive this therapy to prevent possibly one relapse. And as Dr. Smith told you, there's no difference in overall population, in overall survival in the population. Now, I knew that Professor Smith is going to look to the fact that there are subsequent therapies which could alter the results of this trial, and that's why we do not see a difference. But I think the principal problem here is that the separation of these curves occurs relatively late, at 6 months. And by the time it happens, most of the patients with primary refractory disease have already progressed. And this is actually shown very nicely in this slide on the right, where Ali Bog at Mayo Clinic had looked at over 2,700 patients with large cell lymphoma treated. And you can see the patients who truly progress through the chemotherapy and the ones who relapse early do very, very poorly. Patients who have late relapse do much better. And we know it in the clinic. The worst of the worst patients are the ones who progress early. And unfortunately, this trial had no impact on those early progressions. The separation occurred late, and that's why this trial did not produce overall survival benefit. And I don't think even with additional maturations for 10 or 20 years, it will do so. The second issue which Professor Smith mentioned is the cell of origin. And it is a big issue, but this is heterogeneous disease. And what we had seen, that the benefit was primarily reserved to patients with ABC subtype of diffuse large B-cell lymphoma. There was absolutely no difference in GCP subtype, which is more common, by the way. And there was really no significant difference in classifiable site. In fact, there was an opposite trend. So normally, I agree with Professor Smith that you would not consider over-interpreting subset analysis in any trial. You want to really adhere to the inclusion criteria. So if the trial showed overall survival difference, I would be very worried about over-interpretation of those subsets. But this trial does not show any survival difference. So even if we are affording ourselves to over-interpret this difference in ABC patients, we are not really putting anybody at jeopardy because overall survival in this trial is no different whatsoever. And as Professor Smith mentioned, this was a very well designed and very well randomized trial. Now, our friends from northern United States, Canada, are looking now and implementing this algorithm in their treatment. And I would like to thank Dr. Scott for sharing this slide. You've seen it at the his lecture, and essentially they are planning on treating only patients with ABC subtype of diffuse large B-cell lymphoma or non-GCB subtype with polar R-CHOP. So only patients with ABC subtype. Why? Because they are mindful that there is no overall survival difference in this trial, and this is the subgroup which actually can truly benefit from this therapy. So is it really a standard for all? I don't think so. And as you see, there is additional stratification, molecular-driven stratification there as well. Now, Professor Sonali Smith could also mention here that, or sure he did, that there are some landscape is more complicated. There are many more subtypes, and maybe some of those molecular subtypes are actually buried in GCB, which could benefit from this therapy. And and you can see here, this in case of EZB subtype, that maybe there is some benefit in this molecular subtype in this not planned subset analysis. But if this is true, if truly there was a benefit in this subtype as a part of ABC or GCB patients, it means that other patients in GCB cohort would need to do worse, because there is absolutely no difference whatsoever in PFS in GCB patients overall. Finally, we are now moving way beyond it, and Professor Smith showed you this analysis as well with her interpretation. Here the interpretation is the C5 molecular subtype is the one which is probably the most likely to benefit from this therapy, as we know from Dr. Ship's lab. And this shows you again this complexity in the interpretation of this trial. So no overall survival difference, PFS difference in only ABC patients, and even if we try to divide it molecularly, those categories of the patients who could potentially benefit from this trial can change. Now, FDA actually had an oncology drug advisory committee meeting on this, and I show it here because I thought Dr. Professor Smith can actually mention it against me. So what happens is I voted for approval, and I particularly like cancer letter because they have my picture from medical school, but in my vote, and when you vote in an advisory committee, you need to justify publicly your vote. I said that I would consider this regimen to be an option, important option for building for the future, but not a new standard in this setting. Now, Professor Smith also showed you there are many more trials which are currently ongoing and in development, and she was very excited about this. And I would point to you that only one of those 8 trials is using polar R-CHOP as a control. The rest of the trials are considering R-CHOP as a standard therapy in a broad population of patients with diffuse large B-cell lymphoma. So, and this is including the trials which were developed already after publication of POLARX results. So, I hate to say it, but investigators can show you the direction of the standard therapy in those trials. So, in conclusion, Pola-V R-CHOP is not adopted worldwide. I think that's clear. Some use it in all patients. Some use it in none of the patients. Some use it in ABC or maybe even non-GCB defined by Hansel and Gretel patients only. Certainly that's what we do in our practice. And one could use it even more narrowly in the future in some of those molecular subtypes. Now, why we can allow ourselves this subset interpretation? Because again, there was no overall survival difference. We are not harming folks by doing so. As you've seen, this is not a standard for ongoing global phase 3 studies. And I think most of us would consider this as an important option, but not a standard by most of the regulatory agencies as well, including our friends up north. So I asked ChatGPT, actually, after I asked how Dr. Smith debates, what's her position on this issue? And the ChatGPT surprisingly said, she does not really consider this to be a new universal standard of care, right? Now, I was shocked. I couldn't believe it. I mean, that's impossible, right? I mean, I'm debating here. So I asked ChatGPT, are you damn sure that this is the case? Are you sure? And then Chat basically put those nice quotations here. Yeah, I don't believe we should abandon R-CHOP. Exciting step forward. But in my opinion, we should still keep R-CHOP going. So So based on those citations, I say no, polar hardship is not a new standard, but it's an option, important option for some patients and building for the future. And thank you very much for your attention.
Thank you. Now, vote quickly, please.